So today I'll be talking to you about guidelines for the use of corticosteroids for chronic pain interventions. I'm from Pittsburgh, Pennsylvania. So I want you to understand the guidelines. I also would like to thank Dr. Benson, who's not here, but he's an amazing individual. Later in his career, still has more energy than I do, and he's really helped lead these guidelines. It's really impressive. So the one on trigger points and sympathetic blocks has been published in RAPM, and the joint one was just accepted. So I'll give you a little insight into that. Talk to you about the guidelines, talk to you about the evidence of effectiveness of corticosteroids. I hope after this talk you decrease the use of corticosteroids. And discuss the complications and evaluate the clinical evidence. Here's the grading system, United States Preventive Task Force grading system. And we'll talk to you about what the grades are, some of these indications. But I think we all can realize that we overload patients with steroids. There's no doubt about it. We either use them when they're not indicated, or we give doses that have shown no additional benefit at higher doses. So we use 80 milligrams rather than 40 milligrams. I see this in my area. It drives me nuts. I can see these patients that walk into my clinic. I look at their skin, and I said, "Who did you see?" And I already know who they had seen. And they clearly have HPA issues already, and it's sad to watch. They get injections every 3 months. They get 120 milligrams of methylprednisolone. It's really sad. So let's talk about sympathetic blocks first. So this is the first guideline published. This addressed sympathetic blocks and peripheral blocks, trigger point injections. And one of the things we do address in these guidelines is the use of image guidance, which Dr. Rosenquist did a great job discussing. So there's really no sufficient evidence when you're looking at sympathetic blocks to recommend one type over the other when you look at just the evidence base, but I think it's clear that you can't do a lumbar sympathetic block with ultrasound, and I think it's clear that ultrasound's really good for stellate ganglion blocks at seeing structures that you want to avoid. I no longer use fluoro for my stellate ganglion blocks and haven't used it for many years. So here you can see one of my patients that had sympathetic block. You can see it's this is obviously a stellate ganglion block at C6, so you're hoping that it gets down to C7T1. And you're seeing the anterior tubercle, you're seeing the C6 nerve root, you're seeing the longest colli muscle, and you're seeing the prevertebral fascia. And where you see the red star is where you want to deposit the local anesthetic, so the fascia is being lifted off the longest colli muscle. And you can also see the carotid, you can also see the vagus nerve in the carotid sheath with the blue arrow, and you see the sternocleidomastoid. So I think there's no doubt ultrasound has made this a really better procedure in my opinion. It's actually much faster to do once you understand the technique. There's so many vascular structures in the neck. You have the inferior thyroid artery, you have the ascending cervical artery, which runs right up the anterior tubercle. When you start to do this under ultrasound, which I'm sure many of you are doing, you realize how lucky you've probably been in your whole career not hitting some of these vascular structures. The inferior thyroid artery lies somewhere between the C6 and C7 junction, and it comes right across where you're going to place your needle. Lumbar sympathetic blocks, obviously fluoro. So, should you be using steroids in lumbar sympathetic blocks? The evidence would say no, that there is no advantage to adding steroids to these blocks. Furthermore, in some of our sympathetic blocks, such as ganglion impar blocks, there's been the same challenges that we have with particulate steroids with radicular arteries can also be seen with transient cardiac equinus syndrome been published and a conus infarction from a ganglion impar block. So, first thing is the guidelines do not recommend steroids for sympathetic blocks. Second thing is if you still want to use them, be very careful because consequences can happen. Here you can see a study in cancer-related pain. This is lumbar sympathetic blocks, and what you can see is patients were treated either with 10 milliliters of quarter% bupivacaine or 9 milliliters of quarter% bupivacaine and 1 milliliter of triamcinolone. And actually, there was no difference in outcomes. Here you can see the conus infarction after a ganglion impar block. So be very careful with particulate steroids, even in the lower lumbar sacral spine. So the recommendations: addition of corticosteroids to lumbar sympathetic blocks and sympathetic blocks in general, not recommended. Grade C recommendation based on the United States Preventive Task Force. So I think many times we give steroids because we think that local anesthetic doesn't last long. If we add a little bit of steroids, maybe we'll get some extended relief. The studies don't support that. So when you look at greater occipital nerve blocks, you can do this either with a proximal or a distal technique. I like to do the proximal technique at C2. Ultrasound guidance is recommended. This is a grade A recommendation. You can see the greater occipital nerve, semispinalis muscle. That's the proximal approach. So this was comparing ultrasound guidance to no ultrasound guidance, and they assessed patients at 4 weeks, at 1 week and 4 weeks after treatment. So short-term study, and used about 22 patients and 23 patients in each group. And what you can see is that the ultrasound-guided group did better when you looked at VAS scores on the y-axis and time on the x-axis, and it was significant. So if you want to add corticosteroids to greater occipital nerve blocks, the only one you would have a recommendation for from the guidelines would be with cluster headaches. Obviously, if you're not going to get benefit from the steroids, you can have consequences, as I showed, with the ganglion power block. You can also have other consequences, such as Cushing's syndrome, local atrophy, pigmentation changes, so you have to be careful with the drugs. Trigger point injections. I see this all the time, too, like I'm going to give you trigger points with steroids. So, if you remember, if you're a female and you're post-menopause, you shouldn't get more than 200 milligrams of steroids per calendar year, at least, or you're at higher risk for osteoporosis and vertebral compression fractures. Well, if someone's given you 80 milligrams of steroids on every epidural that they're having, and they go to the orthopedic surgeon and they do your knees and your hips, you have trochanteric bursitis, which again, there's limited evidence for steroids for that, because most likely it's a gluteus medius tendinopathy. You really can reach that 200 milligrams pretty quick. And so we have to be careful. We have to keep track of how much steroids people are getting, not only in our office, but outside our office. And so when you look at trigger point injections, let's talk about image guidance. There is some suggestion that image guidance is helpful when you look at cervical myofascial pain. And there's obviously accuracy. I think anyone that's doing rhomboid trigger point injections obviously likes to see the lung. And so I think you have to be careful. And I think it actually ensures that you are in the muscle and not in just the subcutaneous tissue. So this was 41 patients with trapezius myofascial pain syndrome. They used SWE, or shear elastorography, and they looked at outcomes, and many outcomes: manual muscle testing, range of motion, pain, visual analog scale, shoulder pain and disability index, neck index, disability, 20 patients in each group. So again, small studies. I would encourage everyone in this room to do research. You realize when you're actually writing guidelines, there's on some of these things we do every day, there's not many patients in these studies. So 4 weeks from baseline, what they found was in the group that got image guidance, you can see the p-values, VAS, NDI, shoulder pain, and disability index were all improved in the individuals that used ultrasound. There was no significant changes in MMT and range of motion. Here's a steroid recommendation. Addition of corticosteroids, not recommended, and may be associated with complications. So, trigger points, please do not use steroids. Save them for something where they work. Piriformis. 47 patients diagnosed with piriformis syndrome. Either got 5 milliliters of lidocaine 2% or 4 milliliters of lidocaine 2%, plus 1 milliliter of corticosteroid under ultrasound. I actually like using lidocaine on these injections because, as you know, the sciatic nerve runs right below the piriformis, and if it does leak down, you don't have someone in your clinic just sitting there waiting for their leg to return to function. So they looked at the numerical rating scale and the Likert analog scale. And what you can see here, there was no difference between the two groups. Both groups improved, but there was no difference between the groups. So for the piriformis injection, the addition of corticosteroids was not found to be helpful. So in summary, you can see here, I'm not going to read this because we went through it, but you can see a nice summary table that's in the guidelines where steroids may be indicated, such as with cluster headaches with greater occipital nerve blocks. So let's talk about joint injections. How many people in the room, if they had knee arthritis, would get a knee injection? but they had bad knee arthritis. So actually, let's say it's mild to moderate. And the doctor said, I want to give you a knee injection with corticosteroids. How many people would get it? I don't see too many hands. I think that's because you're well-versed in the literature. So let's talk about image guidance first. There's no doubt, and there's some workshops at this meeting on ultrasound, which hopefully you'll attend. When you look at it, this is a study looking at 244 joints comparing no imaging versus imaging with ultrasound guidance. People had inflammatory arthritis, so these are a rheumatological patient population. They actually found that the ultrasound group had a better reduction in pain, had a better responder rate, a reduction in the non-responder rate, better therapeutic duration, and then when you made cost analysis on this, there was cost reduction. When I used to teach on this like many years ago, ultrasound was getting paid a lot of money in the clinic. Now, when you do ultrasound guidance, it's bundled, so it's not really high amounts of money. So I think the cost studies may be different now, but the reality is that you do improve outcomes, clinical outcomes, when you use image guidance. Here you can see one of my patients where I'm aspirating in the suprapatellosynovial recess of the knee. This is existing evidence on ultrasound guidance in sports medicine, and you can see for all these techniques, getting into the joint, there's no doubt that ultrasound guidance is superior based on multiple studies compared to landmark-based techniques. And if you go back to that other study I showed you about inflammatory arthritis, there's improvements in outcomes. So I think there's definitely reasons to consider image guidance. You can see this for the glenohumeral joint. You can see this for the subacromial space, biceps tendon sheath, joints of the hand and wrist, knee, ankle, and foot. All right, so people that didn't raise their hand, I think they must be worried about their knee cartilage. So if you get a knee injection, like I always tell patients, like once you go down this road, it's a slippery slope. First of all, you're going to get past the studies which suggest you get like maybe 2 weeks of improvement. And I'm also taking away any cartilage that you have left. So when you look at some of the JAMA studies, and you look, and again, we don't have many options for some of these patients. So yes, do I do steroid injections on some people that have knee arthritis? Yes, of course. They're older. They don't have many options. They can't get a knee replacement. They can't have an ablation technique because of insurance constraints. We've explained to them the risk. I mean, there's not many options, unfortunately, right now for people with knee OA besides a knee replacement and medication management. But what you can see here, this was published in JAMA in 2017. They looked at symptomatic knee arthritis, 140 patients. They had ultrasound changes of synoviitis, and they look at cartilage thickness in these patients. These patients got, you hear this all the time, every 3 months, they got a 40 milligram triamcinolone injection. You see this, I'm sure, in your area. Or they got saline. Well, there's two things that are fascinating here. One is I want you to look at the pain scores. Saline's pretty powerful. If you look at WOMAC scores and visual analog pain scores, like this is why placebo-based studies are really hard in pain. It's pretty powerful, right? So you look, so these patients either got every 3 months, they either got triamcinolone or they got saline. And what you can see is up to 24 months. There's absolutely no difference in pain scores. And there's no difference in functional, like WOMAC scores. So, I mean, just might as well use saline and not get the cartilage loss. So then, you know, we always say, so I think in conclusion is, am I anti-steroids for the knee? No, but am I very judicious about using them in the knee? Of course. And if I'm a 45, 50-year-old person and I have a little bit of knee arthritis and my knee's bothering me, I'm going to try everything else before I get a steroid injection. I'm going to try all, physical therapy. I'm going to try weight loss. I'm going to try anti-inflammatories. I'm going to try topicals. I'm not going to jump to a knee injection because I may feel better for a short period of time, but I've caused long-term damage to any cartilage I may have left. Then I hear, well, let's just use more steroids. So, all right, so this is comparing 40 milligrams to 80 milligrams. And you can see, when you look at the Likert scales, in the VAS score, there's absolutely no difference at 12 weeks. So no difference observed between 80 milligrams and 40 milligrams. So if you are going to do it, at least use a reduced dose. Remember, if you're a post-menopausal female, you're only supposed to get 200 milligrams of steroids a year at most. You have one knee injection of 80 milligrams, and then you have stenosis, and you have a high dose on that. You're there very quickly. So we have to be careful. We've had some extended release triamcinolone products made, and the question is these are microsphere technologies. Do these lead to better outcomes? Does the microsphere technology lead to better outcomes with regards to extension of pain relief? And we talk about this in the guidelines. So this was a phase 3 study. It was a large study. 484 participants with knee and osteoarthritis. They had to have an average daily pain of 5 and less than 9. And they were randomized either to saline, the extended release triamcinolone, or the regular triamcinolone, so not the microsphere. And the dose was 40 milligrams, so they did not use 80 milligrams. And the primary outcome was change in average daily pain intensity score. And what you can see is that they both were better in this case than placebo for a period of time, so longer than 2 weeks. But there was no difference between the extended release and the regular triamcinolone. So the microsphere technology does not actually lead to reduction in average daily pain compared to or extension of pain relief. So again, if we're looking from a cost effectiveness standpoint, if you're going to use that technology, the cost should be similar. The one thing it did show is about 30% of people that have knee arthritis unfortunately have type 2 diabetes. And again, when I talked about conservative options, weight loss can be helpful to those patients if they are obese. You can see is that obviously we know after we give corticosteroids that glucose levels increase often. You can see with the microsphere technology that the glucose level baseline was 155. At days 1 to 3, it went up to 163. Whereas the other group went from about 160 to almost 200. So there was better glucose control in the microsphere technology. So when you look at our recommendation from the guidelines, and again, I'd like to thank Dr. Benson for really leading these guidelines, extended release corticosteroids have not demonstrated clinical superiority to standard preparations except for improved blood glucose stability in diabetic patients. Certainty's moderate. How many people have had medial or lateral epicondylitis in this room? So as we all know, tendonitis is kind of a misnomer. It's tendinopathy, right? We have micro tears. Same with like trochanteric bursitis. The most common cause is gluteus medius tendinopathy. It's not an inflammatory condition. It's a degenerative condition. And so, often, again, to try to help patients, we're not trying to hurt patients, but we'll say, hey, we'll give you a steroid injection. And so when you look at these tendinopathies, do these steroid injections help? Again, because we're only allowed so much, and if we're going to use it, it should help. So this was a randomized, blind, placebo-controlled study. And what you can see was this is lateral epicondylitis. They had either a steroid injection, a placebo injection, a steroid injection plus physiotherapy, a placebo injection plus physiotherapy. They look at 1-year global change scores for complete recovery or much improvement in 1-year reoccurrence. This again was published in JAMA. And what you can see is the group that got steroids had a lower complete recovery, and they had a less likely of being much improved at 1 year. Furthermore, they had a greater occurrence rate of 54% for steroids versus 12%. The addition of physiotherapy to those groups did not make a big difference at 1 year. So what can you take away from this large study? You can take away one is that if you get a steroid injection for lateral epicondylitis, it doesn't make you better, and it actually puts you at higher risk for reoccurrence. So there's no indication for steroid injections for lateral epicondylitis. None. Unfortunately, we use our hands all the time, so many of us in this room get these, whether it's medial or lateral epicondylitis. I've had medial epicondylitis. It's not fun, but I did eccentric exercises. It took me about a year to get better. So people have probably seen those bars. So if you have lateral epicondylitis, right, you don't want to do concentric exercises to get better. You want to do eccentric exercises. So you want to load that bar and release your hand down. If you have medial epicondylitis, you want to load that bar and release your hand down. And so these are eccentric loading exercises, not concentric loading exercises. This is meta-analysis looking at 6 studies, 429 participants. These patients had lateral epicondylitis, tendinopathy, as you would say. The studies had to be randomized. They had to be allocated to eccentric exercises or non-eccentric exercises. They looked at pain intensity, strength, or function. And what you can see was eccentric exercises significantly improve muscle strength and significantly improve pain scores. So if someone has lateral epicondylitis, you have to tell them to be patient, you have to tell them to stretch, and you have to tell them to do eccentric exercises, and you have to tell them to take an active role in their health care. Here's another study showing the same things. We do epidurals before, often we'll get referred epidural steroid injections before someone may have spine surgery. And the question is, does this increase their risk of infection like we see in joint surgery? And so there's multiple studies I'm going to go through here. This was a retrospective study analyzing epidural steroid injection infection rate. Data covers spinal surgeries from 2000 to 2017. They looked at timing, so whether it was less than 30 days before surgery, 30 to 90 days before surgery, greater than 90 days, and the primary outcome was postoperative infection requiring reoperation. So they had an epidural, they had surgery at some time frame, less than 30, 30 to 90 days, or greater than 90 days. That was a retrospective study. And what you can see, it was a large study, 15,000 patients. And you can see that for fusion, there was a higher risk for steroid injections, but there was no higher risk for decompression surgeries. So when you looked at people that had steroids before a fusion surgery and people that did not have steroids before a fusion surgery, you can see it was 2.68% versus 1.69%. The regression analysis found that if you were overweight, if your Charleston comorbidity scale was higher, and you had a fusion, they were independent predictors of postoperative infection. Age, and again, if you had just a decompression, there was no difference. This was a systematic review from 2023. Again, looking at lumbar and cervical decompression surgery and determine risk differences for postoperative infections. And you can see that if you had a steroid injection within 1 month of surgery, there was a greater risk of infection. And also, if you were older and you had an epidural steroid injection within 1 to 3 months, you had a higher risk of infection. Cervical, they did not find this. Here's another study published from 2024. This was a systematic review and a meta-analysis of 15 articles. Preoperative epidural versus no preoperative epidural. They looked at odds ratios. And what you can see here is that for lumbar spine, there was a significant increase at 30 days, was less likely at 30 to 90 days, and no significant increase beyond 90 days, and cervical spine surgery, no increase. However, does this mean you shouldn't, if someone's thinking about surgery, you shouldn't do an epidural? I don't think it tells you that, because hopefully you're trying to spare someone, right? So you'd have to treat like about 111 patients with the epidurals to have this occur, and in reality, you might help 3 patients. Like, it takes 1 out of 3 that you would really help. So, the number needed to treat is 3. So, the harm's low, and the number needed to treat is high, or low in that case, so it's better to do it. If you're going to do it, just advise them if they're going to have surgery in 30 days, there may be a higher risk of infection. So we often have people that get vaccines, and we know that steroids affect the HPA axis. This looked at about 5,000 patients, 4,804, and they had received some type of corticosteroid and joint injection. And they also were vaccinated for influenza. In the group that had the steroid injection, around the time they got the influenza vaccine, there was a great relative risk ratio for getting influenza. The vaccine didn't work as well. So the recommendation is obviously if you're going to do corticosteroid injections, give some time in between that and receiving a vaccine. So in conclusion, corticosteroids play a significant role in pain management. Evidence is supported in some interventions, but there's a lot of interventions that is not supported. Lateral epicondylitis, piriformis syndrome, trigger point injections, sympathetic blocks. If you're going to do it for joint pain, which all of us do sometimes just to provide some relief, understand that using higher doses is not helpful. Understand that the relief may be short-lived, which it often is, and understand once you start to do that, you have to start worrying about cartilage loss. When you look at epidurals before spine surgery, there is at least some suggestion from retrospective studies and meta-analyses and systematic reviews that there's a higher risk of infection within 30 days. But again, the number needed to treat is low, so you can treat many patients and help them, and the number needed to harm is high. So it does not mean you should not consider this intervention, that if you do it, hopefully they can wait a little bit before they have surgery. Thank you very much. I hope you read the guidelines.